I believe in muscle memory, and I could sit here and tell you that I was a PICU nurse for 50 years someday, but unless I'm actually embodying the role. So there are, for example, there are simulations required at Connecticut Children's for cardiac arrest.
Mm-hmm.
And people will challenge me and say, aren't you tired of being treated like a new grad and you have to sign up for just as many sims and you have to prove
Oh, the
competency, the
resuscitation.
resuscitation sims? And I say, absolutely not. The day that I sit and say I don't need a refresher on codes, anyone who goes to a code sees areas of improvement. We witness a lot more in the pediatric realm, respiratory arrest.
Mm-hmm.
But the simulations that the hospital have us do, I go there, it's unpredictable. You don't necessarily know. The patient condition can change and whatnot. And I'm part of cardiac arrest so infrequently because a child's heart stops so infrequently, it's usually a respiratory issue, that I don't feel expert at that at all. And I've been in a handful of cardiac arrests, but not to the point to say, no matter what gets thrown at me that day, I don't need to practice.
Mm-hmm.
How do you predict and practice cardiac arrest without simulation?
Yeah.
Welcome to the Clinical Appraisal Podcast. My name is Ian Lane, and on this show, we discuss the science and theory of nursing. I'm a critical care nurse and PhD student in nursing science focused on measurement and methodology. Importantly, nothing I say constitutes nursing advice. This is education only. And if you want to get in touch with me, please email me at clinicalappraisal@gmail.com. If you want to donate to the show, links are in the description. And otherwise, like, comment, subscribe, and share the show if you enjoyed this episode.
So I'm here with Dr. Karen Braccialarghe, KB, as we call her in the PICU. Did I say your name
You
correctly?
did.
Aha. She is a professor of nursing and the director of the undergrad program here at University of Hartford.
Yes.
Why don't you take a moment to introduce yourself for the listeners, and then we can go from there.
Okay, so hello. As Ian said, my name's Dr. B, and I have been a nurse since 2002. I went to Salem State, now university. It was Salem State College when I went, and earned my bachelor's in nursing and got my first job as a new grad in the PICU at Massachusetts General Hospital. So I was a new grad at MGH and worked there for almost 5 years. And then I transitioned home to Western Mass and got a job at Connecticut Children's Medical Center in their PICU in 2007. And that's where I remain as a staff nurse. I am a per diem staff nurse there and still practice. And somewhere around 2012, I started to feel some signs of burnout. I could articulate it much better now to say what I was experiencing was absolutely burnout. I didn't recognize it right away, but I knew I wanted to change, so I advanced my education. And my original plan was to get a leadership role within the hospital setting. So I earned a master's in nursing education in 2015, and the leadership roles related to education didn't work out for me. Budgetarily, I was still utilized for staffing holes. I was never able to do the work that I was really hoping to do. I was hired to educate and coordinate the continual renal replacement program in the PICU, which I did, but I was constantly pulled for staffing. So I was offered a job teaching, and I took it, and I became full-time faculty in 2015 at Elms College. And then I realized that in order for me to excel in the world of academia, I needed a terminal degree.
That tracks.
So in 2018, I went back for my doctorate and completed that in 2022. And now I'm at the University of Hartford directing the undergraduate program.
That's awesome.
Yeah.
So they're lucky to have you.
Oh, thank you.
Jealous of some of your students. We had good teachers too, but it would have been nice to have somebody like KB. So, couple things. First of all, I didn't know you were at MGH.
I
actually.
was. Mm-hmm.
There's a peds nurse at MGH I think she runs the Munn Center for Nursing Science over there now. Jen Cahill. I don't know if you would have ever come across her, but she works up that way still, actually. Interesting. So, and you've been in the PICU your whole
My whole
nursing
career.
Very cool.
My time at MGH is invaluable.
Yeah.
I would not be the person I am, the nurse that I am. It literally was the most special gem. The landscape of our profession has changed tremendously, but I was the only new grad in the unit, and I was fostered by experienced nurses that had a minimum of 15 years experience.
Wow.
And I literally, so the residency program for the physicians was through Harvard Medical School. The specialists, the doctors, the education I got for those fundamental years at MGH was irreplaceable.
That's amazing.
Irreplaceable, yep.
I wonder, and you don't have to say when this was, I think you said it earlier, it was like 2005-ish, like around that time?
Yep, that I worked there.
That you were there?
I was there from 2002 to 2007.
Okay, all right.
Yeah.
So back then, this was pre-COVID, clearly, like well before COVID. This was also, I think, around the time that some of the burnout literature is starting to come out, but before you yourself got to a place where you felt burnt out, according to your story, right? What you said about being fostered by nurses with 15 years experience, it really resonates because, nowadays that doesn't happen as much.
No.
Like I'm a fairly new nurse comparatively, and we have some amazing nurses at Connecticut Children's who've been in the PICU for a long time, but there are fewer than there were. And I think that's true everywhere now. There was I think 18% of our profession after or during COVID left the bedside. And so a lot of these experienced nurses are not there to foster some of these new grads anymore.
Right.
So that experience really resonates.
Yes. I was taught that one of the major ways of competency to achieve competency in nursing practice is time. You cannot go from novice to expert quickly. And time as a construct in the profession, we are now expecting nurses to do things after 6 months, 1 year, where I believe that I am proficient and experienced, which helps. That being said, I'm always learning still, and there's always room for improvement. But a new graduate nurse nowadays doesn't necessarily, and it's a choice on both ends. It's the nature of younger generations to want to move forward or go somewhere different. So unless you commit yourself, for me it happened organically. I wasn't consciously thinking about it. So in my nature, I'm more of a homebodied person. I wasn't looking to move away or explore other places, and I was very happy and contented. I also love being part of a team, and nursing provides that if people stay. And there's turnover, and I've had so many great team members through the years. But for the first, I would say even 10 years of my career, it was a lot of consistency. And you're right, it's very hard to find that now.
Yeah. Let's back up for a moment
Sure.
and just kind of circle back to what you were saying about your trajectory. So I'm interested, you have your master's, you're teaching, were you at Elms?
I was.
You're teaching at Elms, and you're realizing, like, I need to go back. And so everyone in nursing who wants to go back to get a graduate degree at the terminal level, the doctoral level, they're faced with this decision tree. Usually it's like, do I want a PhD or a DNP? Or in your case, do I want an EDD? Like,
Yep.
What was the decision tree for you, and why did you select what you did?
It's a great question. I was lucky. I feel like I've been very lucky with mentorship and having really great people around me when I decided to make different decisions. And at the Elms, Dr. Joyce Thielen, who has her PhD in nursing from UConn, chatted with me, and she did say that it was in my interest from the trajectory of my career in academia to get a terminal degree. And then you have the choice. So as I searched through programs, I would look up, there was two things that I wanted. I wanted a PhD or a doctorate in nursing. And every PhD program I looked at, I realized quickly the focus is not teaching. And so nursing research demands a certain level of knowledge for research and data collection. that really was not my passion. And so I had already been hired full-time at the Elms, and I wanted to be in a classroom. And then I started to learn, this is going to sound very juvenile in a sense, but when I would be in my dean's office or when I would go to the provost's office and I started to learn who these influential people were at the university level, their degrees on their wall said EDD. And I thought, I want the degree that the dean has. What is that degree? And realizing that the PH, the philosophy, the doctorate in philosophy gets you to more research, the ED, the doctorate in education, I was like, this makes so much sense. I want to be an educator. I want my doctorate in education. And then I found a program. There's only two that I know of. One's in Columbia, one's at Southern Connecticut. It's a doctorate in nursing education. So when I looked at most EDD programs, they're enrolled by a lot of people in K through 12. So a lot of high school principals, school administrators, superintendents, they go back for their EDD. There was a degreed program for an EDD in nursing. And Southern's program is a candidate of a nurse faculty loan grant. So it's funded, 80% of my EDD was paid for through that grant, which is really unusual to get scholarship or funding for a doctorate. I did consider the DNP. And then I was part of a generation of nurses that believed that nurse practitioners earned a master's degree and were operating at such a high level, functioning at such a high level, that they believed that they could form a degree program for clinical practice at the doctoral level. So the spirit of a lot of DNP programs was for a practitioner to not need an overriding MD to prescribe. And then probably for the market's sake and trying to be competitive for consumers, schools started offering DNPs in things like leadership, things like management. So it was getting further away from the clinical. And then when I learned what a dissertation was and what a terminal degree was versus the DNP project, I felt that I was doing myself most justice to understand curricula, to understand teaching strategy, that I couldn't find a DNP program that within 3 years would afford me that kind of prep. So I went with the EDD program.
That's fantastic.
Yeah.
So you chose to get that's what I was going to say. I think Columbia had one of the first doctorate degrees in nursing ever, actually. And it was the EDD in nursing education. It was like one of the first threads into the realm of doctoral studies in nursing was the EDD.
Yes.
And I feel like people often forget that it's like a really fruitful way for us to go. There's a woman I'm doing a research study with, if it gets funded, from NCSBN on how to measure clinical judgment in student nurses.
Yes.
I was telling you about that.
Yes, we need this.
At work. Yeah.
Yes.
And her name is Janet Monagle. And Dr. Monagle, we're doing this project where we're trying to use confirmatory factor analysis to factor out this new clinical judgment measurement model that they developed.
Okay.
And to see if we can derive that from case studies.
Yep.
So we can talk about that another time, but her whole justification for me, aside from the fact that we need to have a measure of clinical judgment that we can get from like questionnaires and case studies, and not just from behavior, from watching students,
right?
Which is partly why we're doing this, if we get funded. But she explained to me that she's so passionate about nursing education, and there's so few scholars in this realm. There's so much needed to be done in the area of nursing education.
Yeah.
And I feel like people forget that you can get a terminal degree in nursing education where your whole dissertation focus is like on something related to educating, teaching.
Correct. So part of your work, it has to get funded. I feel very biased about it, but just understanding NCSBN's new test plan of how we are now licensing nurses to study that method. The NCLEX test plan went to a case study method, so the questions mimic case study decision making. So how do you evaluate that as far as a response linked to clinical judgment? It's a very important thing to research. And yes, the EDD that I'm enrolled in, because I don't know if it was because of the grant, but just the nature of the curriculum of my EDD, my dissertation provided structure. On one hand, I felt intimidated about picking a topic for dissertation because we were put somewhat in a direction for it. I had to pick a topic that was identified as a need through NLN for nursing education. So I could not do something clinically based. I would have felt very comfortable picking a topic related to pediatric critical care.
Yeah, I would imagine.
But it had to be under the umbrella of NLN nurse education research needs.
They didn't have anything like that for inpatient critical care nurses?
Not so. The grant, the language through NLN was very much geared towards the academic, not the hospital educator. And so my cohort of students primarily were academics for nursing programs versus clinical educators, because in the hospital, a PhD or an EDD for the hospital setting isn't necessarily the benchmark. That being said, we did have a few hospital-based educators that chose a topic related to educating staff. But the NLN needs for nursing education are really centered around undergraduate programs.
Yeah.
Instrument developing, like what you're doing of measuring clinical judgment. And simulation was a huge realm for some of that need as a teaching strategy. So that's why I picked my topic of study.
Yeah. So tell folks what your topic was, because it's integral to that.
So I wanted to study something about sim. And there's so much that's been studied on simulation, especially with nursing. Pam Jeffries is the guru of nursing simulation. And there was a huge study published in 2014 that was a big win for simulation, because it showed that when you compare learning outcomes through clinical education and learning outcomes through simulation education, there's not a difference. So a student is able to learn through simulated methods just as much as they are through traditional clinical. The study also exposed some gaps with clinical education, and I believe now it's another topic for another day, but some of the rotten wood, I call it, of clinical education, I believe is hospital retention and turnover. Because if you don't have experienced nurses at the bedside to model behavior, how do you get them to be clinical instructors, and how do you get to teach a student in that setting? So oftentimes my students are hiding behind linen carts, trying not to screw anything up, but they're not actually learning direct patient care. But in simulation, I can achieve that. So there wasn't much to look at there. And then COVID happened. And I had to put my undergraduate courses in the spring of 2020 all online. And I taught accelerated nursing students and traditional nursing students clinical courses. And when we learned that the governor said, we're not going to stop the pipeline of nurses, however, the hospital said, you can't come here. And the college said, you can't come here. So I could no longer access high-fidelity mannequins. I could no longer access real patients. And they said, but you need to get them ready clinically to make clinical decisions and to pass their boards.
Good luck.
And we thought, what are we going to do? So we had to use virtual methods. So my dissertation was exploring nurse faculty decisions related to virtual simulation before and during a global pandemic. So what were we doing with virtual sim before, and what did we do after? And what I found was, obviously we used it a lot more during, but the barriers to virtual sim include cost. If universities don't budget virtual simulation, faculty training the trainer, how do I use these methods? There's a huge gap in debrief. We've gotten down high fidelity debriefing for sim. There's a lot of learning that takes place in the debrief, not so much with virtual. And the need to pivot during survival mode was one thing, but there's a lot of opportunity now that we're not in survival mode to improve simulation methods, and studies show that it's here to stay. Virtual methods are not going to go away. They won't be used 100% of the time, but they're going to be used in nursing curricula moving forward. So there's a lot more that I could look into with that.
That's really interesting. Do you know if they're used in other professions as well? I would imagine like PA students and physical therapy students and other people would probably have had to have done something similar. They
did in healthcare, yes. And then the research that exists for VSIM, a lot of aviation. There are flying techniques that a person only simulates. They don't actually do that. Medicine, there's a lot of surgical techniques that technologies and robotics have you simulate. There's not a lot published for nursing of what we do virtually to teach our students.
Interesting.
Yeah.
Wow. So you looked at some of the barriers. And actually, before I forget this point too, you mentioned debriefing.
Yes.
Are the difficulties with debriefing because there is no debriefing with virtual, or is it because it's limited in some other ways?
So if you were to, so I teach MedSurg 2 in this program. And if you're a student in MedSurg 2, you go to class, you go to a clinical every week, and you also go to a 2-hour skills lab. So we have our technology center, the Hersey Center at UHeart, and so you as the student go into the lab. But by senior year, when you're taking this course, we've trained you on a lot of skills. So there's a simulation area of the Hersey Center, and so my lab has simulations through the semester that the student has to do. Debriefing is a structured part that if I say, how do I best deliver a simulation method? I have resources for that. I have published grids for that, guided questions for that. If I now want to implement a virtual simulation method and I want to know the best way to debrief, I have nothing. I could literally do whatever I want to do. I can't seem to find tools, resources to say, am I debriefing virtually with the student? Is it a post-test? Is it me recording feedback? What ways do I debrief with them on their performance through a virtual activity that would be as meaningful as ending the in-person simulation and debriefing as a group? There's just not a lot of known methods to debrief virtually. So it's an area of opportunity, I look at it as.
Are there other areas that are kind of glaring and stand out in terms of being able to make it more successful as you go on?
So I would say virtually, there's always going to be an element. So we already have the barrier of buy-in to simulation. I work with phenomenal educators, and they will not ever believe that it's the same as clinical education. That being said, I have seen breakthrough learning happen in simulation that would never happen. We teach a mental health course in our curricula, and you can rehearse, or even our maternity simulations, you can rehearse debriefing for bereavement that you can't do. A student can't be part of those conversations. They're usually kept out of the room. So let's say tragically a family loses their child in the PDED, and then a nursing student wants to know, how do you handle those conversations? How do you give support to the family? You can't do that in clinical.
Right.
You can simulate that. We hire live patients. So instead of having high fidelity mannequins for our mental health, we have an actor come in and simulate mental health disorders. Virtually, it is hard to simulate some of that layer of realness with that. But I will see a student go down a decision-making tree in front of me in high fidelity sim that I can't interject and say, no, you prioritized the wrong thing. A virtual simulation can do that for you, and you get stopped in your tracks, and you have to think, why am I being kicked out at this level? What did I do? It's a lot more self-reflection, and it's more self-guided virtually. So I think that some of the products now that they have for virtual sims are very helpful as a supplement, not in replace of clinical hours, I believe, but it's a good supplement. Yeah.
It's one of the things that stands out to me for, my education happened during COVID. It wasn't during the first leg exactly.
Yep.
But in any case, I had experienced a little bit of this transition to online exclusively.
Yeah.
And, I'm just inherently very skeptical. It's in my nature to be skeptical of everything.
Yes.
But I will say, one of the things, you mentioned the mental health stuff. Actually, it's very hard to simulate a conversation because there's so many layers, and it's like, if you wanted to simulate this conversation, you'd end up missing a lot of tone and context, and it would be really hard to do that and to embed it all in a software program. But what you can embed, the pearls, the nuggets, I actually remember being in clinical after the fact for psych mental health and experiencing a patient with bipolar disorder, or borderline personality disorder splitting, and realizing like, oh, that's what that was.
Right.
And it only occurred to me because I had gone through the simulation
Right.
that I was skeptical of.
Right.
So I do think it's one of those things we often have a bias against it, and yet we don't realize sometimes how it will trigger in the moment with a real patient in front of us, like something we may have learned.
It's great exposure to, it may not be the real life experience you're going to have, but it at least introduces the content, which is so important.
So you've been a PICU nurse for, I don't know how many.
21 years.
21 years. So in your 21 years, it's not like anybody could say like, well, because there are some, and I say this with all due respect, there are some nurse educators and faculty who haven't been at the bedside for a very long time.
Yep.
You are not one of those people. You are actively practicing still to this day.
Mm-hmm.
And you're practicing in a high acuity environment with a lot of pressure and a lot of stress and a lot of nursing skill, right?
Yes.
I say that not just to build you up and make you feel good, but also because I feel like for you to find value in something like a simulation, whether virtual or high fidelity or otherwise, there must be something that you're seeing in it that you recognize as valuable.
Definitely. So I believe in muscle memory, and I could sit here and tell you that I was a PICU nurse for 50 years someday, but unless I'm actually embodying the role. So there are, for example, simulations required at Connecticut Children's for cardiac arrest.
Mm-hmm.
And people will challenge me and say, aren't you tired of being treated like a new grad and you have to sign up for just as many sims and you have to prove competency, the resuscitation sims? And I say, absolutely not. The day that I sit and say I don't need a refresher on codes, anyone who goes to a code sees areas of improvement. I also appreciate that in the adult setting where codes are happening very frequently, and true codes, by definition, I was raised at Mass General to believe that a code is cardiac arrest. Mm-hmm. We witness a lot more in the pediatric realm, respiratory arrest. Mm-hmm. But the simulations that the hospital have us do, I go there, it's unpredictable. You don't necessarily know. The patient condition can change and whatnot. And I'm part of cardiac arrest so infrequently because a child's heart stops so infrequently, it's usually a respiratory issue, that I don't feel expert at that at all. And I've been in a handful of cardiac arrests, but not to the point to say, no matter what gets thrown at me that day, I don't need to practice. Mm-hmm. How do you predict and practice cardiac arrest without simulation?
Yeah.
So I find a lot of value in that. For my students, I do believe that my students of today, they are drawn to technology. It may not have been the best method for my generation of learners or learners before me, but they enjoy, they feel very comfortable looking at a screen and watching someone virtually deliver nursing care. They don't shy away from it. They may not believe that it's the end all be all. They also, I think that I have a theory about nursing students that they want to be considered a nurse when they go to clinical. Mm-hmm. They have a mindset of, you're putting me in the practice setting, so I want to function and I want to be the nurse. Now, ownership of care, though, when they're actually in clinical is a whole nother story. Mm-hmm. So it's such a discrepancy of, do they value virtual sim the way that they value putting on their uniform and going to a hospital? Mm-hmm. But where does the learning take place? And I do believe that they're able to learn because of simulated methods. And I will always believe that because I do a lot of research on teaching strategy, and lecture is just not the way to go. Mm-hmm. It's proven. They want lecture and they want me to lecture to them, but the active learning is how it actually happens.
Yeah.
So
I'm sure there are ways of lecturing that you can embed within, doing something.
Yeah.
Like a simulation, for example.
Yep. I pull up virtual scenarios a lot in class. And they'll watch someone who's shoveling out their driveway, start to have chest pain, and I'll pause and I'll say, what's happening here? So I bring that kind of layer into the classroom. And it's a nice way for me also to see them connect the dots or do something a little bit different.
I feel like there are a handful of lecturers in my, now I'm in grade, 23.
Yep.
Who knows at this point. And in my whole educational career so far, I can name a handful of faculty members or educators who have like inspired me or taught me something that I've retained to this day
Yep.
through pure lecture alone.
Right.
And the consistent theme with all of those is that they're weaving a narrative and a story together that makes sense for me in some context.
Right.
And so, in the clinical space, it's always they're weaving a narrative of a case study, let's say, or
Yep.
like something that I can connect the dots, as you were saying, versus just like pulling up a PowerPoint and going through like bullet point, step by step, like pieces of information.
Right.
That's not
Right.
where it's at anymore. Is I think what I'm hearing from you.
Yes, and there's definitely, I think there will always be feedback. We evaluate our classes and we look for feedback from the students, and sometimes there's mixed reviews. Sometimes students will say that I tell too many stories because I have so many clinical stories, but that doesn't help them for exams. And even though you could probably say, well, the story is linked to the content, objective testing makes students very, very anxious.
Oh,
and
yeah.
so they really want the concrete, what do I need to know for the test? She went on and on about a kid that she took care of. But then some of my students give really positive feedback saying that they love hearing my stories about me being the nurse. So there's definitely probably a mixed bag
Yeah.
of that.
There's bound to be innumerable ways that we could look at breaking down nursing education into different types of buckets of things that need to be improved.
Yeah.
I mean, you mentioned earlier like the gap between hospital-based nursing education and academic nursing education. That gap I feel like needs to be traversed somehow. I don't know how exactly. And
I agree. It's so hard because the evolution of our profession, we went from being a very simple role of assisting the physician and being an assistant to the environment and those core, notes of nursing, of clean bed sheets, fresh air, but also providing a human piece. I used to work with a attending from Connecticut Children's who has since retired that would say in his philosophy of medicine, he didn't focus very much on the human element with his patients and families because he believed the nurses would tend to the nurturing and the caring part of it. So his bedside manner was very clinical. But now we've gone from that perspective of what a nurse is to managing care, being in a Western modern healthcare environment. A nurse has to know so much now. You not only need to understand the pathway of the medical piece, you have to know how to deliver care in all these complex systems. So I think that hospital-based educators get a nursing student out of school and they think, well, how has the school prepared you to be a nurse? And the school thinks there is so much theory that I have to teach them. I have to provide direct patient care hours, but without an RN license, and because of the security of the electronic healthcare record, a nursing student can do about this much of the role. And so a lot of it is observational. How much do you learn through observation? There's so much on-the-job training that has to happen. And so the gaps are tremendous. And I really believe in, if it was tied to the old ways of nursing practice, schools of nursing were phenomenal. You would be a student in a school of nursing and you would go to a hospital 5 days a week. But you also didn't go to those schools and earn a bachelor's degree.
yeah.
You were kept at a very vocational place. Now it's a higher level of education. And then you have the skills that you have to learn. So and that too, it takes time. When you're in clinical for 8 hours a week doing med-surg nursing, how much of that do you really master?
Well, med-surg is huge too.
I know.
I interviewed my grandmother, who was a nurse. She was a psych mental health nurse for 40 years.
Yeah.
I think it was episode 87 or 88. And she talked about how she did a diploma program within the hospital.
Yep.
And every day they went to the hospital for their education. And they had some lectures, but mostly they were apprentices under the nurses, the nuns, at the time, for, 4 years.
Right.
And I think she ended up getting, well, she definitely got her bachelor's because she ended up getting her master's degree too. But very much like what you're saying. And now, because of all the advancements we've made, which are fantastic, we're in this predicament where there's so much to learn on the academic front that there's this gap with practice that then has to be filled later.
Right.
So, and we could talk about that another time. I do want to get back to kind of what you're going to do from here. But before we do, I just want to say I am fascinated with the question, and I did like an 1.5 hour long podcast recently on this by myself where I just talked about this question of what does it mean to advance nursing practice? And because everybody, when you think of an advanced practice nurse, you think of like a nurse practitioner.
Yep.
But then I work at the bedside as a PICU RN with people like you and Michelle, who I'll have on the podcast soon. And there are people who have these, sometimes decades of experience who I learn from in ways that are not just like, how do I reconstitute this medication? Because there's a skill that you learn, like if you want to make a 1-to-1 medication for whatever your task is.
Yeah.
That's a skill. You do it 3-4 times. You eventually master it. You know how to do it. You can teach it. You can show that you can precept, whatever. But then like performing that skill with a parent there and reassuring the parent, and then realizing that that child has a developmental stage and trying to weave in their developmental normativity into your practice too. And like I watch you guys do your nursing practice and I think to myself, like, that's why they're an expert nurse. They don't need to go get a different license to practice a different profession, let's say medicine. And that's a whole conversation we don't have to have right now. But like what you're doing is advanced to my mind. And I learn from you guys every single day. So the question of like, what's the reason there's this big gap in all this theory? It's like we have an independent license. We practice within this developmentally normative framework for human development. And there's so much to learn. You almost can't close that gap. You have to have these two domains of learning. One is like pre-licensure, post-licensure learning.
Yes.
What are your thoughts on that? And then I'll go back to that point.
So I think what you're describing, wisdom with experience is not something that is quick. And you get a feel for something, and sometimes you're wrong, but as the years go by, there's something that I don't believe you can teach other than exposure of time. Meaning the skills become second nature. You do, and there are ways though that you can falter thinking that you're doing something 100 times, so therefore I know, you have to return to that process. I really do believe, aviation does this, Lifestar does this. They do checks. EMS does this. They do checks of their bags, their equipment. It's so mundane. Yes. Check. But
The
if
OR does that.
The OR, if they don't, a mistake could happen.
Absolutely.
The clinical judgment, the all-knowing of having a feel for your patient, being intuitive to what they might need, and then also really gaining an independence of, I was raised in an environment of nursing where I was told that we were one team. However, nursing is not a paired activity. And I teach this to my students because in the ICU, we do a lot of things together, but on the floor, nursing is an individual activity. And I was taught, even in the PICU in Boston, if you're going to ask someone for help, you better really need it because you're taking the nurse away from their patient. So I don't want to see you asking for frivolous things that you could do yourself because, and also at Mass General, we didn't have PCAs. So it was only nursing. So we did everything head to toe. And I was very autonomous, doing a lot of things on my own without asking permission for it. Our nursing scope of practice was big. It did include more medication preparation, but then even the delivery of those meds. So it was a lot of autonomy and a lot of ownership of accountability. And over time, there are very rarely times in my practice where I look and I think, someone else is responsible for this. Someone else needs to worry about this. I own the patient care for 12 hours. And I don't think you can embody that or do that within your first year of practice. I don't think that you do that if you don't have it modeled to you. And this is where it's really hard to be new to nursing because you're surrounded by people who don't have the experience. So how can they model that behavior when they're not that experienced? So it is a very, very difficult thing because while the turnover is happening and while the staff is newer and newer, patient problems seem to be getting more and more complex. So I really think that you're going to come out of nursing school hopefully with a really well-rounded education of what the generalist nurse should know. But you're going to go into a practice setting that until you give it some commitment and time, you're not going to master that because you went to school.
Yeah.
It's just not going to happen.
You're laying a foundation.
Correct.
You know.
And when you think about it, it's not apples to apples, but a physician goes through medical school for 4 years before they touch a patient.
Yeah.
They don't do a residency until after they have their MD. There's no practical practice. It's all theory. It's pre-med, med, then residency. Nursing school combines it, and so nursing students think, well, I'm going to be a nurse. I'm going to go to clinical today and function as the nurse. It takes so much time to do that.
Well, and they're changing that a little bit. Like, we have med students in the PICU.
Yep.
They're like 3rd years, 4th years.
You're right. Yes.
But they don't do anything.
No.
They're only
it's
there
observational.
to observe.
Right.
So even that distinction, like, the PCA experience of nursing students, which I always find that to be kind of interesting because, like, when I was a nursing student, I had a similar feeling. Well, I want to learn how to be the nurse.
Yep.
We're here to be nursing students, not to be PCA students for the nurses.
Right.
The thing is, though, what I realized retrospectively 2 years later, as I look back and I think, oh, yeah, the dignity of the human experience, I don't think there's another profession that exists that I can think of. And of course, I have such limited experience. What a wild thing to say. But I can't think of another profession where you have such an intimate inside view into someone's life and someone's experience. And if you don't take care of someone's activities of daily living and bathe them and wash them and, help them, as Virginia Henderson would say, do the things that they can no longer do for themselves for whatever reason, I think you can't really understand what it's like to be a nurse, because the way that I define nursing is very much like Virginia Henderson's definition. We are an extension of the patient for 12 hours or however many hours you're with that person.
Right.
And to eschew that stuff as PCA work, I think, is to forget what it means to be a nurse.
Yeah.
But then one of the things you learn after, so like, yeah, you get out, let's say you join the PICU, you do some codes, you do some code meds, you drop code meds for ECMO, you learn about ECMO and chugging and flow and all this cool stuff, and then you realize, like, but then, like, that kid on ECMO has a family who doesn't understand, and so part of the education role comes in, and then they are in a developmental stage, and if they're constantly sedated to the point where they're out of it, they're not learning, they're not growing. I've seen videos of nurses at different children's hospitals taking their kids on ECMO for walks on low sedation. Like, that is a level of expert nursing that just, like, but you realize after you learn the technical skills that we are more than just technicians with skills.
Right. And I think there's a excitement and newness to do skill.
Yeah.
That being said, you articulated it perfectly. For me, being a nurse, it's such a privilege to be with a person at their most vulnerable state, and the compassion that everyone deserves during that time, where I've always taken care of children, and depending on the age, yes, I take care of children who are closer to the age of an adult versus a child. Being humble through those moments where it is not easy to have someone take care of your personal needs.
Yeah.
And it is not easy either to be dying when you're only 10 years old. So there's a lot there that we could talk probably all day about what I believe a person should show up with in terms of compassion and things that don't have anything to do with the technicalities of the profession. It's a really well-rounded individual that we're looking for. I feel so lucky teaching nursing students. My students, they are in a snapshot of life where they are so focused on the goal of becoming a nurse that, yes, they're afraid of the exams. the evaluation assessments, the formative assessments, the grind of nursing school. It's hard.
It is hard.
But they are wanting to take care of strangers for a living. So they come to me already with a nature that they're just good people. They're kind and they're compassionate. And there's, not everyone excels at everything, but they all bring to the table where, for the most part, I can say that I literally have taught nursing students that I think to myself, they're going to master their craft someday, and I would want them to be with me when I was ill. And there are things that you can and can't teach certain things with that, though. And it's a learning curve because they just believe, like, I want to start IVs now. It's like, you're not licensed. But they have the quality in them already that they want to take care of someone.
Definitely.
Which is important.
Oh, I know we're rapidly approaching the time we have to go. So
I know.
What is your next step, and what are you most passionate about? What grips you the most from here?
So now I direct the undergrad program, which is a learning curve. I'm learning more about the admission process into a nursing program, the succession and progression of our program. I'm learning about outcomes, the new AAC and essentials. So a lot more of the kind of administrative level to what it means to run a nursing program. And that will be what I do here in addition to teaching. And my next steps, I do need to publish. So I have to do research. So this semester, actually, because I did so much for my lit review and I did so much related to simulation, I found only one study that compares simulation methods together. So you can find a lot on virtual sim. You can find a lot on high fidelity sim, not as much on virtual. But nothing comparing the two. So I got IRB approval this semester for my med-surg class, and my students are going to partake in a high-fidelity simulation during their lab, and then they're going to partake in the same simulation virtually. And then they're going to flip-flop the order that they do that. And
so they're all going to get so it's like a crossover study.
Correct. It's a crossover study. So they're both going to do these two simulation methods. One group will do virtual first, one group will do high fidelity first, and then the other groups will do them separately. They'll be graded. There'll be a rubric on their performance of the high fidelity sim. There's learning objectives that they'll be evaluated on with the virtual sims. And then, so I'll compare those to say what were the learning outcomes when they did this virtually versus high fidelity. But the part of this, so everybody's doing that regardless of the study. The part that I consented for was I'm asking the student to rate their level of competence of care after the high fidelity sim and after the virtual sim, and to see was there a difference with the simulation method that contributed to their competence of care. And I'm going to collect data for that this fall and probably write that up over the summer. And then I am determined to get a accurate or adequate method topic for the PICU. I really want to research in the PICU and find a project, find a research topic that it's going to contribute to improve patient outcomes in the PICU. So I am constantly racking my brain of what to do. My role here takes up so much of my time as an educator and now as the director. And then I do work roughly 4 shifts a month in the ICU. So to find time to then do a decent lit review and find the gaps of what could I research in the PICU that I could then write up and collect data for and analyze. But I am expected, my hired track here, I do have to do scholarly activity. So
yeah. Well, this has been really awesome. I could clearly talk to you for another 3 hours.
I know.
Karen, thank you so much for joining me. I really appreciate it.
Thanks for having me.